Welcome to the lecture on rheumatoid arthritis. In this specific lecture, you will learn more about rheumatoid arthritis and also some of the therapeutic treatments for rheumatoid arthritis. So, what is rheumatoid arthritis? So, it's actually a very prevalent autoimmune disease that affects about 1% of the world population and about 1.3 million here in the United States. And then for every 100,000 of people, about 20 to 50 cases are going to be diagnosed annually. So interestingly enough, females tend to be diagnosed more likely, specifically women in their 40s. These are diagnosed twice as likely as men. And then disability is very common because it's such a severe debilitating disorder, and about 35% of US adults have work disability after 10 years. So rheumatoid arthritis, I can't stress this enough, this is a very complex disease. It's basically a chronic systemic inflammatory disorder. What happens is your own immune system sort of turns on itself, and instead of attacking foreign pathogens such as bacteria or viruses, it starts attacking your joints. So you have joint destruction of the cartilage, and it's a very debilitating disorder. There's a strong genetic component to it, but demographic and environmental factors are all thought to contribute as well. And what's important is that patients that have rheumatoid arthritis versus healthy individuals, these are actually going to have increased mortality rate, and it's possible that their life expectancy could decrease by 3 to 10 years, and this is because cardiovascular disease is so common in them. And also death due to infection is common because, a lot of times they're on immunosuppressants to sort of help mitigate function of the immune system, and then as a result they're more susceptible to the infection. So strong genetic component to the disease, we already talked about that. So before, back in the day, it was thought that disease sort of progresses in a very simple, continuous manner. But now we actually identified that there's different ways that rheumatoid arthritis can progress. So polycyclic or polycyclic, this is basically going to be majority of patients. What happens, you have mild symptoms, these are going to resolve in weeks to months, and they tend to occur intermittently. And then severity may actually increase in subsequent episodes. So next time you have your episode, your symptoms can be much more severe or greater than when you had your episode last week. Monocyclic or monocyclic, this is about 1/5 of patients or 20%. Symptoms occur suddenly and then patients go into remission for a prolonged period of time. And then progressive or 1/10 of patients, disease basically continues in a very steady manner, and the manner can be either very slow or very rapid. So let's look at the etiology of the rheumatoid arthritis. So we talked about before, it's a complex multifactorial disease. There's a strong genetic component to it, and these two specific genes are thought to contribute. And then the following genes having these genes may actually increase your risk of rheumatoid arthritis, STAT4 and CD40 locus. And then smoking is thought to contribute as a strong environmental component. And then lastly, infections are very prevalent in patients with rheumatoid arthritis, but actually no pathogen has been identified as a causative agent, meaning, if you get an infection with bacteria, blah, 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 you can't get the rheumatoid arthritis from that. There's no link to getting a rheumatoid arthritis from having an infection with a particular pathogen. So let's look at the pathophysiology. So basically, we talked about before, what is a synovial lining? When we looked at the anatomy of the joint, and we looked at the glossary of different terms. But just to remind you, synovial lining is going to be a thin membrane that's covering the joint surfaces. So what happens is rheumatoid arthritis is that you have this inflammatory pathways, and they're going to cause proliferation of the synovial cells in the joint. So as the synovial lining undergoes proliferation and basically form what's known as the synovial pannus, and it's basically just a giant glob or mass of cells that's going to invade the joint and is going to cause cartilage destruction. Just like in osteoarthritis, we had cartilage destruction. The joint space also becomes narrower and the joint is altered. You have erosions of the bones or osteoporosis, and you have destruction of the tendons and the ligament. So end result is that you're going to have deformed joints. And then there's three on the molecular level. There's three key molecules or entities that are thought to contribute, and these are TNF alpha factor, interleukin 6, and then just pro-inflammatory cytokines in general. So you remember TNF factor alpha. We talked about it before. We talked about Humira. So TNF factor alpha is a key cytokine that's going to be responsible for the damage of the joint in rheumatoid arthritis. And we talked about that biologics. These are specifically medications that target TNF factor alpha, and they target it very successfully. For example, Humira is a monoclonal antibody that's going to bind to TNF factor and basically, prevent, inactivate it, prevent its involvement in inflammatory pathways. So by using biologics, we're going to be able to achieve remission in large populations of patients. Unfortunately, biologics are very expensive, so prohibitive costs are going to present challenge in underdeveloped countries, and also because what you're doing is essentially disrupting the mechanisms of the immune system. So you're basically disrupting your antimicrobial defense mechanism, because that's what your immune system does. So you're lowering your immunity, increasing your susceptibility to infections. So how does a rheumatoid arthritis actually present when you have a patient come into clinic? How would a physician diagnose it? Well, clinical presentation is actually crucial for diagnosis because no single laboratory specific test is actually specific for the rheumatoid arthritis. So presentation and symptoms are key. So basically you have pain, stiffness in the joints, specifically interphalangeal joints, the wrists, and then the symptoms can vary in severity. And you can have systemic symptoms. You can be tired, you can be feverish. Some people have weight loss. So those are systemic symptoms of rheumatoid arthritis. These are the diagnostic criteria that the American College of Rheumatology published in 2010. And then these are the diagnostic tests that can help you diagnose rheumatoid arthritis. For example, rheumatoid factor and this anti-citrullinated antibody, protein antibody, about 50 to 80% of people with rheumatoid arthritis have either one or two or a combination of both. So this specific rheumatoid factor, it's basically an antibody in the blood, and it's present in many people in rheumatoid arthritis. Unfortunately, can also be elevated in other autoimmune diseases, for example, hepatitis C. And this specific antibody, it's a more specific test for rheumatoid arthritis, and it's thought to potentially be involved in etiology of rheumatoid arthritis. And then these tests, for example, C-reactive protein, CRP test. So this can also help you identify rheumatoid arthritis. It's actually part of the new classification criteria because CRP along with SCD, which is erythrocyte sedimentation rate. So these are both markers of inflammation. So you can actually use them to monitor disease progression or even a response to particular therapy. And then CBC, or complete blood count, is typically done as well, just to monitor your overall health and screen for anemia and stuff like that. And then what is our treatment approach in rheumatoid arthritis? So early treatment and prevention are going to be key. The earlier you diagnose, the earlier you're going to be able to treat. And then management in the last few decades have undergone drastic changes from treating symptoms to actually treating it to target. And basically the goal is to prevent irreversible damage and occurrence of disability. You also want to relieve pain and inflammation and swelling in a joint, and also allow an individual with rheumatoid arthritis to continue to working and pursue personal activities that they may like to do. And then you're going to treat them with a combination of rest, physical therapy, occupational therapy. They need emotional support because this is a debilitating disorder. And then pharmacological management, obviously. So methotrexate, it's a disease-modifying drug. It's sort of like a first line for rheumatoid arthritis. Then biologics are going to be second line for rheumatoid arthritis. We can use them in combination with methotrexate or just other drugs. So you would use methotrexate, disease-modifying drugs, and then biologics, and then joint replacement is basically a final resort that you would resort to when the symptoms can't be medically manage when you have such severe joint damage. So this concludes the end of lecture 1. Thank you for your time, and please continue with me to the lecture 2 for rheumatoid arthritis.